you've got. And yeah, we'll make a start. So good to have you all along. If it's your first time, we do this every month, and it's sort of just sharing POCUS learning cases, interesting things. If anyone would like to speak, you can get in touch and present. That'd be great. And yeah, the title this week is Cases Where POCUS Saved Our Bacon, and we've got both the vegan and the normal non-vegetarian bacon, which I think is all equally appetizing there on the screen. And the name for the title of the talk was given by a colleague who sent a message saying, I heard you did a scan and saved our bacon. So I thought, yeah, I needed a way to bring a few cases together, so that's what it is. So to save one's bacon is a 17th century idiom where it's to rescue one from failure, danger, or disaster to prevent something bad from happening. And I wonder if POCUS was around for these pilgrims in the 17th century, this is how it might have looked if they were having a look at this patient who looks, definitely well resuscitatable, maybe not on the screen. But the main reason for this month's topic is because for us in the wonderful world of pediatrics, we know it's really tricky. Kids are excellent at hiding things. They may come in with headache that doesn't have a head cause, tummy pain that doesn't have a tummy cause, or they may have pain all over. They may have a simple graze and be really distressed and upset, or they may come in with these lovely banana arm like this one and be completely fine. So within that, we use POCUS as a tool to try to help things. And I'm sure you all know the kind of role of POCUS, an extension of your clinical exam, to try to take us from a position of pre-test probability to one of where we're at post-test, just the way we would with any other examination, I guess, or any other, test, for example, blood tests. So often my department, I'll be asked, will you have a look at them? I don't know what's going on. Or, I might just be curious and think, right, can I do a scan on them? So today's cases are really all a collection of different things where I really didn't expect what I found. In some cases, it was really serious for different reasons. And it was a bit of an opportunistic scan, only on the basis that, I was able to do that, or I was interested to do that, not really because I had any particular clinical acumen to go to do so, or to go and do so, but just because I had, I guess that skills and the interest to try and do it. I mean, just last night we had another case of intussusception in our department, just again with very non-specific signs. So it's quite an interesting one. So first case is a 16-year-old boy, and this happened not too long ago at all. This case is shared with full consent from his family and from him, and he had a bit of shortness of breath, which he was hard to describe, but he described one episode of collapse. So that was the main reason he came in. The resident doctor assessing him said, I wasn't involved initially, I was doing something else. And he said, how's the lad in that room? He said, yeah, he's fine. He seems okay. Had a little look at his observations and wondering what the plan was going to be, and everything looked pretty okay. But yeah, I was just a bit curious really. And I glanced at his ECG, again, shared with consent with the dates on. And, we see lots of different pediatric ECGs. Sometimes you'll really look and look and look, and you might look for kind of P waves, and you might think of this sort of, V1 to 3, the kind of typical non-specific T wave pattern, the idea that the T waves are going to reinvert over time from infancy, early childhood to teenage years. But I've also seen 12 and 13-year-olds have all T waves here doing nothing. But there was one other thing that interested me a little bit, other than the heart rate being slightly high. It was just this. It was just the kind of lateral leads, the sort of, I guess, inverted T waves really is what I saw. Again, I've seen ECGs of a similar nature where it doesn't mean anything or hasn't turned out to mean anything. But I was interested. So I went and have a little look at them. And on the way, I got a bit of extra information looking through the notes, which I did think was interesting. And it was the triage nurse, this is obviously copied direct from the notes, saying that while he was in triage at the age that he's at, he was having fleeting tachycardias up to, really significant levels for someone of that age. So I thought, okay, this is interesting. What am I going to find, if anything? So I went and had a look at him. And the story I got was a little bit different. He did look okay, kind of end of the bed, and said that he'd been seeing his own GP for what was described as pleurisy on and off. And I said, so you were treated with antibiotics for infection, did you mean? He said, no antibiotics. They just thought this was pleurisy. But then when I dug into history a little bit more, I got a real story of two terms that I haven't used for over 15, maybe getting on for 17, 18 years, which is orthopnea, an adult thing, kind of trouble laying down when you're in bed, particularly, whereby you have to prop yourself up with breathing. It can have a number of causes, but usually sort of cardiac or respiratory. I'm sure the adult mixed EM guys on the call will keep me right with that one. Not something we really hear about, particularly in pediatrics. And also something called paroxysmal nocturnal dyspnea, whereby this lad had gotten up in the middle of the night, short of breath, and he'd had 2 episodes of collapse, particularly the night before, which I thought was really unusual for a seemingly fit and healthy 16-year-old lad. As I say, he looked all right, he was chatting, but he just had a very slightly sighing respiration pattern, just like a little bit like, just a bit like that. Not tachypneic and not really working hard to breathe either. So I did what I'd always do, which is to extend my clinical assessment using POCUS, and this is what I found. Put the probe on. Thought, oh dear, we've got a big right-sided pleural effusion. We've got our positive spine sign here above the liver, and we've got clearly a decent amount of fluid. I couldn't really see any consolidated lung nearby that I would normally expect to see when I get this parapneumonic effusion. And I thought, no, this is a bit bigger than that, so this isn't going to be that. Left side, same thing. We've got spleen, we've got stomach behind it, kidney, and again, we've got that positive spine sign there at the bottom where the transmission of the pulses through the fluid show us the spine above the diaphragm. So I was like, okay. And then, yeah, of course, I went to the heart, and boy, was I surprised at what I saw. So got a heart, parasternal long axis, and within that, we've got a large amount of circumferential fluid, anterior and posterior. And worryingly, here at the top, the near field, where we hit the right ventricle first, we've got that kind of slight depression of that kind of outflow tract. So it's like, oh dear. Rest of the views, so here's the parasternal short. Again, we've got significant right ventricular compression and collapse, and we've got a large amount of pericardial effusion around it. This is kind of an apical view where we're slightly off axis here and a bit foreshortened of the left ventricle in this view. I just want to share it because it really captures what's going on with the right atrium. And then again, a little bit more evened out towards the end of this view with that same atrial collapse with a degree of right ventricular involvement as well. So I had a look for a nice subcostal, and I was slightly astounded by the size of this pericardial effusion. We've got almost as much fluid as we've got heart visible. I came to the IVC, which is an excellent sign to look for pericardial effusion, pericardial tamponade. It's deemed to be both sensitive and specific when it's taken at such extremes, whereby we're not seeing any respiratory variation or depression. We're at a very large measure in IVC here. Normally take our measurement 2 to 3 centimeters distal to the hepatic vein, which obviously doesn't come fully into view here, but is around about here. So you'd maybe take your measurement there. And yeah, that was an IVC that was massively plethoric, not moving, no respiratory variation, very worrying. Some of the signs we take in isolation or together, which I'm going to talk through in a second, but I just want to measure the extremes of the size of this pericardial effusion. We were up to almost 5.5 centimeters, which is fairly massive by any grading system you look at. So this was his X-ray. You can infer from that what you will. Probably suggestion of obviously pleural effusions bilaterally, but and a big heart, but yeah, maybe doesn't tell as much of a story. And he still looked, I mean, he was sighing a bit with his breathing, but he didn't look kind of too terrible. But the echo clearly was a worry to me. So I'll fast forward a little bit. I ended up taking this young lad down to the coronary care unit where he was the youngest person by 80 years. And yeah, he had aspiration and pericardiocentesis that night where they drained over 1.1 litres of fluid from his pericardium, which again, I thought was extremely sporting. And he's had lots of other investigations to deal with. Sorry, I had no idea that I left the call there. Can you guys hear me all right?
Yeah.
Oh no,
Yes.
sorry about that. What point did I go off? And why did I go off?
You were telling us that the boy had had lots of investigations since you went to the cath lab, and that's when you
Right.
disappeared for me.
Sorry about that. Right, I'm going to reshare. I don't know if we're still recording. Hopefully we are. It's the problem with not being able to keep an eye on the Keep an eye on the screen. Right, I'll go
Then
back a
something
little.
about 1.1 litre having been drained.
All right, is that where we're up to? Okay, cool. So, sorry. Talked about all the lovely physiology. Can you see me in presenter mode there?
Yeah.
Yes.
Okay, really sorry about that. Don't know what happened. So yeah, he did have 1.1 litres drained, and he had other investigations, all of which didn't give us an obvious cause in terms of virology, in terms of a full body CT, which didn't show any malignancy. So just talking through, not all effusions are equal in terms of pericardial effusion versus tamponade. So this is an example of a young lad I had who we picked up lymphoma in the department, and he had a fairly sizable pericardial effusion, but probably no significant chamber impairment. And again, a stock clip from online that shows a decent size of effusion in a different view, where the kind of ventricular function appears to be okay. So clearly a tamponade is a physiological status as a result of the intrapericardial pressure exceeding that of intracardiac and impairing cardiac output, as we might see in obviously some of these clips here. So someone post-operative who might have an issue may lead to immediate tamponade as a result of a rapid accumulation of a big pericardial effusion, whereas somebody who is having the gradual accumulation over time and that counteractive mechanisms of compensation is less likely to have tamponade physiology. So there are different signs that we look for, obviously. The plethoric IVC is a very sensitive sign if it's at the level that it was with my young man, where it was minimal respiratory variation, kind of compression, distension, and sizable. And we can also have impairment of both atria and ventricles. So it's when each of these chambers is trying to fill. So obviously ventricular systole, when the right atrium is trying to fill. We can see, we saw quite well, didn't we, in the clips that I had, whereby that right atrium was really kind of being compressed pretty much in all of the visible views that we've got for it there. And then laterally, we might get the same of the right ventricle in diastole. We've got those mitral valves open during that diastole. We might see that compression of the RV, which to some extent was happening in my case. So this is just a graphical representation of it. So we've got kind of an apical 4-chamber view here showing that, and then we've got the same in a kind of a parasternal long and short, where we're seeing that right ventricle become squashed and compressed. So it was a fairly unhappy looking echo for my boy. One other measurement that we can look at is the sonographic representation of pulsus paradoxus, which is the respiratory variation between inspiration and expiration of mitral valve velocity, measured through kind of continuous, basically spectral Doppler, where we might see between a sort of 25 to 30% difference between expiration and inspiration. This would be the echo equivalent of, pulsus paradoxus, where there's that drop in blood pressure with inspiration, expiration. You can obviously look for changes in the JVP, things like that, but I'm not particularly good at doing that. So it's probably a bit more representative to do it using echo. I didn't think to do it in the case of our boy. I was just desperate to make sure that he didn't become really seriously unwell. And then, we're talking about the different sizes of pericardial effusion. So I think anything over 500 would really be quite large. And where in our case, we've got double that and, 2.5 times the size in terms of circumferential measurement. So it was certainly a very large pericardial effusion. I'm really glad that he obviously overall did well. So a learning point for each of the cases. And I think it's that you don't need to be a complete echo whiz, certainly not, to rule out pericardial effusion or tamponade, and that, the things that you might pick up with minimal clinical signs or a quite low level sounding history, could be extremely significant and potentially even life-saving. Any questions at all about that first case?
Did they get to the bottom of what the underlying cause was?
No, sorry, I was mentioning, so he'd had lots and lots of tests, so all of the pericardial fluid sampled, multiple raft of kind of blood tests, various echoes serially, including a full sort of CT, chest, abdo, probably pelvis, and everything's negative so far, so no viral organism, I guess, that would be top of the list. So at the moment, unclear.
Did the effusion ever come back?
No, he didn't. He's not come back. No, I went to see him. He was in for quite a while. I went to see him. This was the Thursday night. He got fully sorted by the early hours of Friday morning. I went to visit him Monday. He was actually still there, but he was doing much, much better. Just had his drain had just been removed. So yeah, weird one.
Also interesting. We normally, to just butt it, but normally we get taught that any syncope with low voltage tachycardia, you have to always think about pericardial effusion. But I think that rule doesn't always apply for kids because they don't have that much kind of impedance to the electrodes. So you still get big, nice complexes, even though, especially in this guy, he didn't have very small complexes of ECG. So yeah, POCUS makes more sense actually, even in that setting.
Yeah, no, totally agree, Gokul. Yeah, that's a great point. You know, we know the things that are really hallmark that we tend to look for. I guess just much like probably everything in this talk you're going to hear this morning, it isn't always there in pediatrics. I'm afraid we don't always get those lovely clues. But good, yeah. I thought the images were sort of too good not to include that one just to share. So yeah, hope we were all tamping out experts now. So the next case happened a wee while ago, and this was a 3-month-old girl who came in with a lump on her chest. She was term, well, uneventful pregnancy, all the normal kind of perinatal care. And she looked lovely. She was happy, but she did have a lump on the upper left side of her chest. And she had this faint discoloration under the axilla that, you know, that one of the doctors who initially did the assessment thought, is this bruising? You know, if it's bruising, obviously in an infant, we should call it bruising. We shouldn't move around that term. And he wasn't too sure. But of course, the top to toe check didn't reveal anything else. And this really felt quite unusual to assume that NAI was top of our list, when of course it's something really important that we have to put at the top of our list. But it didn't give me that feel. So I went and had a good look. And I found this interesting thing on the chest wall. So this is the scan using the high frequency probe. This is obviously the area that I'm talking about. The rest of the anatomy is the underlying pleura with a star here. We've got, this is actually the rib, would you believe, in a neonate. So it's minimally ossified. So we get minimal acoustic shadowing behind. And then obviously we're in the kind of intercostal sort of space region. And it's superficial, but it's sizable for a small child, I guess. It's kind of, you know, almost a centimeter by like a centimeter by kind of 2/3. With a small kind of baby, it really did sit up on her chest. And I thought to myself, right, what could this be? So it certainly doesn't look like a normal lymph node. If this is any kind of lymph node, it's a worry, but it doesn't have those hallmark features. It's irregular even for an unusual lymph node. It doesn't, you know, of course, you don't want to see a rounded lymph node. That's a big concern. They're normally a 2x1 axis. But it's still irregular even for that. And there's a little bit of increased echogenicity sort of centrally. I can't see an echogenic hilum that a normal lymph node would have. And it's a strange place, so superficial on the chest wall for a single lymph node. So what I thought I was seeing was honestly a hematoma. And it really looks like it's got that slightly irregular walls, the sort of mixed echogenicities. It's obviously dark, so it is kind of fluid in some form. But I just thought, yeah, is this in keeping with what we're seeing, maybe bruising? Is this a hematoma? So in such a tiny baby, obviously one who's non-mobile, I was thinking to myself, well, that's extremely significant based on the level, you know, the mechanism of injury that would be taken to kind of produce a big hematoma and some bruising. You know, I'm not seeing any underlying rib fractures. The child's comfortable and well. So again, injury just didn't feel reasonable. So I guess it prompted us to do other investigations, and we confirmed what we were seeing with the radiology scan just half an hour later, just to be certain. Again, the read from this was that, yeah, that's looking like a hematoma, really. We've got this thing called SMI, which is superb microvascular imaging, which is an enhanced form of power Doppler that can be used to look for sort of inflammation and other signal pickup, like a non-directional dependent Doppler, and it wasn't really doing much there. And then this is a right upper quadrant view. Can anyone eagle-eyed pick out anything from this picture? Because it's really relevant to the final diagnosis. It's a really simple question. What might we normally see in this view? So we've got diaphragm, liver. If anyone's scanning an adult, what do we normally see here?
Kidney?
Gallbladder.
Yeah, kidneys, absolutely, gallbladder. Kidney's going to be sort of somewhere down here, isn't it, in view on fanning through. But yeah, we'd typically expect to see, you know, next to this gas, centrally, we'd expect to see gallbladder. So there's a little clue, all right? So we undertook a more in detailed history. You know, is there any features of trauma, anything, you know, any history of trauma, any of the adults or older children in the house? The family weren't known to children's services. You know, for what it's worth, we were certainly not getting any kind of a vibe of that nature. So I handed this patient over to my colleague latterly, and we'd done some bloods with a bit of a plan as to what we should do next. And I'm going to give you the bloods as they came in and different levels of response to them. So bilirubin, yeah, fine, 2-month there, a little bit up, maybe 131, not too much of a worry. Conjugated bili, 96. Okay, wow, right, we're dealing with conjugated hyperbilirubinemia. That's not what we'd expect to see and not great. So there's my sad face. ALT, yeah, it's up a fair bit. ALP up, but we do see it probably in isolation. That wouldn't mean much in this age group. And then when it really got exciting was when we got this, a PT of nearly 115 with an INR of 7.5. Wow, this young girl is in synthetic liver failure somehow. Why? She looks very well. She's not bleeding, but she does have a hematoma and probably some faint bruising. So we covered it with all of the relevant things you would, treated for infection and gave FFP and gave some vitamin K. And we involved our tertiary liver unit, which is nearby. Well, not that nearby. And yeah, interesting. So she had an echo, which showed some stenotic pulmonary artery branches, and some lumbar X-ray were noted on a lumbar. Pardon me. Some butterfly vertebrae were noted on a lumbar X-ray. Has anyone very clever already picked up the diagnosis? Amazing if they have. It's going back to exam level for us paediatricians. So yeah, this turned out to be a diagnosis of Alagille syndrome. So normally picked up, early in infancy, could be identified through antenatal features as well. Yeah, they typically have a characteristic dysmorphic feature of which our child didn't, and genetically was diagnosed as Alagille syndrome, whereby they have an absent gallbladder as part of it. So yeah, a rare genetic mutation, incidence of between sort of 1 in 40 to a 1 in 100,000, and progression of end-stage liver failure due to paucity of intrahepatic bile ducts. So yeah, I thought that was a really interesting one, just from popping a quick probe on and finding something that was a bit unexpected, and then leading us obviously to do other things. But yeah, just a slightly nice one. So I guess my learning point here was that neonates obviously will come into our department with rare stuff and pick up even potentially genetic diagnoses opportunistically. That not all bruising does, of course, mean NAI and non-mobile infants. We have to have an index suspicion about medical causes as well, as we did. And I think just that POCUS can pick up other things in detail. I mean, if this had a child had just kind of planned for safeguarding medical on the basis of, is this bruising? And we hadn't really had to think about what that lump means, we might not have kind of kept such an open mind and acted in a more medical fashion, I think. So yeah, it's quite an interesting one. Any questions about that one? No. Okay, so next case is that of a 14-year-old boy, and he'd had some vomiting and some central abdominal pain for a couple of days, but he looked okay. He had ASD, but had no physical health problems, and he looked all right. He wasn't particularly dry at this point. He'd came in overnight, kind of late, and was there early hours of the morning, next day when I came in, having been in early hours, and he had a soft, non-tender tummy. So this was the plan from the night team. They were happy with him. They were going to consider the Andan's-Atron and then get him away post-fluid challenge. And he looked quite happy. So I went and had a little look at him. And I popped a hand on his tummy and I started to do some scanning. So what do we think? Is this looking all right or not so all right?
Not so all right. There's dilated bowel loops, I think.
Excellent, great. Yeah, definitely. So this child really looked fine, but I knew this was a really kind of serious looking appearance of his abdomen. So we're seeing lots of things, aren't we? We're seeing some dilated loops of bowel. You could measure them. This is 10 centimeter scale, so they're pretty sizable. That would be 5, so they're pretty big. We're seeing some interloop-free fluid here. We're seeing some little triangular interloop-free fluid called the Tanga sign throughout, and we're seeing these kind of really prominent valvulae conjuventis in between, which really just gives you a nice graphical representation of being fluid-filled. We're not really seeing active peristalsis. So POCUS for bowel obstructions actually really been demonstrated to be an excellent and sensitive sign. And I kind of thought that's what I was dealing with. So I asked one of the team to just order me a CT, and they were sort of wondering what I'd seen based on how well he looked. Had a little look with a high frequency probe. We've got little bits of localized free fluid down in the right lower quadrant. got this sort of little structure here that stands out a bit to me, and then again some slightly localized free fluid, which out of context might not mean too much, but given the rest of the caliber of his bowels, I was quite worried. So I measured this little structure, which I thought was suspicious of an appendix. So this is what I'd noted. I was just copy and paste directly from the notes. I said some dilated loops for a little kid up to 4.2 centimeters with prominent valvulae coniventi, tangocine interloop-free fluid, and possible appendix lower down. So I just said grossly abnormal, he needs a CT, even though he looks quite well. This is what I was telling you about, this valvulae conniventis. They call this the piano key sign, where you see these little protrusions coming in against the backdrop of the kind of anechoic fluid. It's quite a specific sign. And he had his bloods done at that point, which were slightly, again, not in keeping with how he looked, but obviously a big, big worry. And this is a CT. So in essence, it showed that he had significant obstruction, dilated loops, and a bit of a caliber change lower down with the suggestion of the appendix causing the problem with the localized free fluid. So yeah, that's what he had. He had a perforated appendix with obstruction. Don't ask me exactly why he obstructed. There was no, I don't believe there was any fecalith. Yeah. Yes, possibly. They said possibly on CT. I can't remember the op note. I don't remember if there, you need a really good fecalith when you lead to bowel obstruction. It's nothing I've seen for someone who scans lots of appendicitis, but thought it was interesting. So yeah, this child looked really well, and I think I found that bowel obstruction doesn't always have to present with a big tummy, and that I guess we should always keep an index of suspicion when we get a handover about our patients from the night team or from a different team. I was always taught to just go in and maybe have another quick look based on my own opinions myself. So try to do that if I can. And yeah, POCUS for bowel obstruction is a recent really big systematic review with large numbers of patients that has demonstrated it to be an effective sign. I guess it's a nice, quick, easy sign that we can repeat that's safe for the patient. Getting a CT might be tricky in terms of justifying that radiation, justifying it to a radiologist, is it needed? And also, whether we can get a small child safely into a CT scan for 5 or 6 minutes to get a full series. Any other questions about that case? No. Okay, so this was Adrian. Are you still on the call? Maybe not. Can't see the chat. Okay, if you are, put a thumb up. But so this was the child who came into our department recently, and this is what it says. It was cough and query increased work of breathing. Numbers weren't particularly exciting, and in essence, this I think represents pickup of the year, is what I would say. So as part of the history, the person who saw them, who's our POCUS fellow, had understood as well that there'd been no other physical health issues except which had some sort of strange walking since the time of acquiring kind of gross motor milestones, and that the family had been back and forth to the GP, but actually it never sort of been limp as such, and they'd never been referred into PDD, but they were finding it sort of slow going. I think the orthopedic letter says that there was slow progress. So because obviously she's able to do that, our POCUS fellow did POCUS of her hips, and this is what we're seeing. So this is the unaffected sort of side. For, I think the description of limp was obviously unilateral, right side, I believe, or the odd walking, shall I say. And this is the unaffected side, and this is the affected side. And can everyone appreciate a difference with that? Thumb up if anyone can see what I'm going to describe. So hip effusions are the thing we tend to look for. We're looking sort of somewhere down here, looking for, this capsule underlying the sort of iliopsoas muscle on top. And this is obviously our physis and our epiphysis. We're seeing the femoral sort of metaphysis up here. So, normally you'd see some effusion there. That's not really what we're looking at. I think a few people in our department who do some scanning with me have seen how easy it is to look for effusion, and it's pretty easy, but that's not what this is about. So can anyone hazard a guess at what we're seeing differently here?
Has the growth plate been wiped out?
Yeah, it's certainly really unusual in that region, isn't it? So I think I've been trying to follow this anatomy. We've unpicked it with all of the orthopedic team who are great, really. They know we do a lot of scanning and they're dead support of the pediatric guys. And of course, you know, the person who scanned and the supervising consultant, even who's very experienced in POCUS, wasn't too sure what they were seeing. So they wanted me to have a look as well late at night. And I think what we're seeing is we've got this kind of, you remember this is the anterior recess. We're looking down in this direction above, not left, right when we're scanning. So we're seeing a normal capsule and we're seeing the sort of metaphysis come up. And really where we've got this physis and we've got a femoral head, we don't really have any femoral head to speak of. This is actually all part of the sort of, you know, the metaphysis coming up. So you're exactly right. We've got this instead really speckled appearance here within where the femoral head should be. The synovium, pardon me, does normally look speckled. There can be other things you might look for as well within a femoral head. If you're seeing it for stippling or speckling, you can see signs of avascular necrosis, but it's probably a little bit beyond, you know, what ultrasound would be ideally used for. But I totally agree. It doesn't look anything like it. So this was a sort of oblique / transverse view, just trying to get a bit more detail about what's going on there. And I think it shows it. This bit is meant to be the femoral head. So you can't, you know, a bit young even for Perthes, I think, and it could be an advanced Perthes theoretically from this, but it's not like anything I've seen. But in fact, the pickup was much, much more unbelievable. So well done to the person who did. I don't know if they're still on the call. And it was this. Anyone happy to guess what the diagnosis is in this 2.5-year-old? So if we look at this X-ray first, we might worry, is this what we're seeing? Is any of it projectional? But it's actually not. If we look at the greater and lesser trochanter, everything's pretty equal. We're basically seeing this tiny, funny little femoral head. But what's happening here? It's completely just. Go on. Go on. Be brave. It's completely
I thought it was
dislocated.
a upper femoral epiphysis.
No, so well, even worse, I'm afraid, for this poor little
Someone
kid.
said,
This,
dysplasia.
yeah,
of the
it's a myth. It's a missed CDH. Can you believe this poor little 2-year-old has been walking on this since birth, since acquiring more milestones. It's completely dislocated. So this is CDH. Can you believe? So came in with cough, some clever sausage, had a good look around just because they can and because it's quick and easy, and no patients ever. Not really seen many kids not tolerate a hip scan. It's probably going to happen now loads, isn't it, when I go back to work tomorrow? But yeah, quick and easy to do, and picked up something really interesting. So yeah, 2-year-old girl admitted to hospital with a cough, and when she was in the hospital, noted she might have had a limp and was scanned, and yeah, has been walking funny ever since. So she's going to get sorted out, thankfully. And I just thought that was a great pickup. So when the scanning for DDH, CDH, it's a totally different scan. It's scanned in the coronal plane here. And we kind of look at this triradiate cartilage view. And what you're looking for, these different angles here and here, the kind of alpha and beta angles, of which obviously I don't get involved with. So it's a totally different view, but ours would have been significantly abnormal if we'd have done that particular view, which we wouldn't have done because it's not within our skill set to do that. But yeah, so learning points I think here are that kids are amazing, aren't they? And they can adapt and compensate and mask really serious things, just the way our boy was masking a big, huge, enormous pericardial effusion. You know, they can also be walking around with a dislocated hip for 2 years. Poor thing. So hip POCUS is dead easy and it's dead helpful and it's well tolerated and the parents love it. If you show them the fusion and explain what we're talking about when we talk about irritable hip, I've always seen that they're really engaged with what we're telling them and they've got that visual representation of a hip effusion. So it's often really, really helpful for them. And it may, of course, direct you to do x-rays in someone who you wouldn't normally do. I mean, it's not that commonly we'd want to be x-raying every single sort of 1.5, 2-year-old necessarily. Of course, we'd do it as part of our workup if we're still worried. But I think hip scanning is a really nice initial test to do for most average limps, where, of course, transient synovitis is going to be a big collection of what we see, massive, overwhelming group. Any questions there at all? There's another case. I've shared this one in a different talk. Hopefully not all of you have seen it, but I just thought it had to go into this group. So this is again shared with full consent, published in a journal. And this was my little girl who pitched up to me one weekend, and it was Saturday afternoon. And she, in essence, had been treated for queretae of this eye. and had been back and forth to the pharmacist, had seen a GP, and she came into us. And in essence, there was no sty to find. And she certainly wasn't getting better with hot water bathes, that sort of thing. So what I found was just very subtle. I don't know if anyone can pick it up from this picture at all. It's just very slightly. One of the eyes looked a bit bigger. I was like, okay, is this new? So I did a scan, and I guess I'm looking for a few things. I might have been looking for anything sort of ocular, or I'm probably really looking to see if anything's behind the eye or any, raised intracranial pressure for optic nerve sheath diameter, of which we're taking this kind of measurement somewhere in here. We're looking for this retina here, where we're hoping not to see what this girl has, which is some papilledema. But can anyone else see anything else on the screen that's kind of really shouldn't be there? So all of this tissue here, all of this is abnormal. This should not be there. It should just look completely uniform and homogeneous and echogenic. If you can see this, just in this view here, it really does just look like something extremely, extremely worrying, which unfortunately it was. So I had to kind of beg to get her an MRI that afternoon because I knew what I'd seen and I knew it was extremely abnormal. And unfortunately, it was this horrible tumor, which was a rhabdomyosarcoma, which is something that's really worrying. It's often picked up fairly late in pediatrics, depending on the site of which it is. And it's obviously it can be an extremely aggressive cancer. So a little bit of a strange one, again, shared with full consent from the family, who, I know quite well now. And yeah, it's a rare malignancy, but within pediatric cancers, it's one of the ones that, I guess, it's within some of the pediatric cancers that we do see, but sadly, but thankfully overall it is a rare thing, and it can be different. It's to do with the undifferentiated mesenchymal cells, and can present in different forms in different parts of the body. But effectively, it's a tumor of muscle and connective tissue. So she got all of that sorted. She had some proton beam therapy, and she had other chemotherapy. And I'm chuffed to say that she's been given the all clear very recently. So I think the learning point here is just that if you do see something on POCUS, you don't need to always understand every single thing you're seeing. Of course, you're going to then follow it up with definitive imaging, radiology, ultrasound, or something else, depending on how worried you are. But it is a test that is, easy and quick to do and might save a life, potentially. So if something doesn't look like it should be there, then you're probably right. Any other questions about that case? No? Okay, so this was 20-month-old who came in, who was not using the right arm. See that an awful lot. And the suggestion there from the triage nurse was this pulled elbow. So obviously I like to have a look at kids with pulled elbow. So put the probe on along the radiocapitellar line as we normally would. So we've got the brachioradialis muscle overlying there. Here we've got distal humerus. We've got capitellum here. We've got this supinator muscle sitting over the top. And had a look, and this wasn't a pulled elbow, but I did see something else. Can anyone see anything else on the screen? So sort of this here and this here, this anechoic material here within the joint, this is a joint effusion. So I guess theoretically it could be traumatic, but actually, there wasn't too much in relation to too much from the way of trauma to suggest anything, but certainly wasn't pulled elbow. So in pulled elbow, we've talked about it quite a bit. If you've been in any of the sessions or teachings, whereby this supinator muscle coming over forms this positive hook sign. Now this does look, of course, very abnormal, but actually this and this was more abnormal. So I was like, okay, we've got an effusion. Is this trauma? It's a small child. Again, this is the longitudinal view, posterior in the olecranon fossa. So this is the humerus, this is distal triceps, and this would be a similar view to what you get, whereby the echogenic fat gets moved into a different position due to typically a traumatic effusion, so injury. And this looked not, it was a fusion, but again, it just looked slightly unusual. And then this is an anterior view, which I sometimes do just to work around the child. So we're looking at the anterior part of the elbow here. and we're seeing the different heads of the bicep muscle here and probably brachioradialis sat on top there. And again, this fluid is all abnormal, so it shouldn't be there. So we had an effusion, and we got an X-ray, and it said the same. It said we've got an effusion, but no obvious fracture. So it's sort of like, what do you do in this scenario? You've got a child without any mechanism of injury who could have a trauma or could have something else. So we had to have a bit of a think. The bloods were done, and they did show a little bit of inflammation, actually. You know, at this point, we're thinking, do we have to consider anything of safeguarding nature, you know, or do we just kind of have a bit more of an open mind? So between ourselves and the orthopedic team, I was asked to come and have another look with the scanner. I looked using a high frequency hockey stick probe. You get kind of nice close-up views with a reduced depth, where again, we could see an effusion, possibly a little bit of stranding within that effusion, this linear hyperechoic region there, the kind of, you know, slight, yes, sort of stranding, really kind of increased echogenicity, which was suggesting maybe something else was going on. It could be all blood, but also could be infection. Had a little look with power Doppler. Again, you get a nice close-up view, but couldn't really pick up anything additional within that. And then again, I was starting to look at the sort of distal humerus to see, is there any little buckling? Is there any little fractures here? And it was kind of a case of, well, what do we do? You know, I've seen a load of kids who've came in with a fracture and actually some bloods have been done and you see a little CRP rise or something. It just something I've seen a good handful of times. So I wasn't really too sure which direction to go down, but the orthopedic team were keen that we should press on and get some definitive imaging. So I sedated her as part of my sedation list that week, and she had DMR and it went well. And she did, in fact, have a septic arthritis with features of osteomyelitis, which is quite interesting. So there's the sort of effusion here. It's the anterior bit. So yeah, quite interesting. She had some pus in her joint space in theatre, and the broth in the end, it didn't, nice picture of broth there, it didn't show it a final organism, but it gave us this readout, or give the orthopedic team that readout. So she had a washout, and thankfully she did well. So a bit of a strange one, just because, you know, the direction was going down one route of pulled elbow, which again, we can scan for pretty easily. Hopefully we don't want to repeatedly manipulate a fracture or you know, something like that nature, but it wasn't pulled elbow, and it led us to do other kind of a more important investigations down the line. And bloods, you know, might not be as indicative of how we would like it to be in terms of inflammatory markers. Any questions about anything to do with that case? No. Okay, this was a little lad not too long ago who was 4 years and 3 months, who came in with a left-sided neck swelling. He had ASD, but was physically well. He was non-verbal, kind of quite impaired in terms of kind of communication and interactions with others. He was difficult to assess, difficult to examine. And with his neck swelling, he was considered to have lymphadenitis and was treated with some antibiotics with a plan to review him and bring him back to make sure that he was settling down. But he really was extremely difficult to assess. He was sort of very distressed by lots of things. And he came back in and he had this large left-sided neck swelling that was no better. And if I've ever scanned a neck and treated, I'd always expect clinical resolution, and the lymph nodes tend to improve fairly readily as well. I just knew that there was no improvement. So I was like, oh no, what have we missed? What's going on here? He didn't have total callus despite the big swelling, and he was very tricky to assess, but we managed to just about get some ultrasound scans with the help of myself, POCUS fellow, and I think another helper, and Mam. So this is sort of the left neck, kind of level 3. And we can see more superficially over the sort of sternomastoid muscle here, we've got these lymph nodes. We've got a collection of different lymph nodes together. They're all maintaining the normal kind of architecture, where they've got very smooth walls. We can see a beautiful echogenic hilum running through the middle there, which is really normal. Lymphadenitis, there's no actual true radiological definition of what it is. You know, how is it more than 3 lymph nodes, 5, 10? It's just it's a cluster of lymph nodes typically. So it tends to be like a bunch of grapes. We see lots and lots all together, so much so that you struggle to count exactly how many are there. You know, this looks like one large one, but it definitely isn't. It's kind of 2, maybe even 3 side by side. Does anyone see anything else that might draw their attention at all, other than these fairly, you know, that's a fairly standard kind of day-to-day lymphadenitis that's not too much of a worry for me, but I definitely didn't think explained his symptoms. Anything else? Anyone want to have a guess? So basically, much deeper in the field, lower down here, we're seeing this big heterogeneous stuff here. None of this should be here, really. We'd just be scanning across to trachea, which would be here, where you just see air and see nothing else. All of this stuff here is a very, very heterogeneous collection. It's a worry. It looks very non-uniform. It's quite large, I guess. It's bigger than all of the other lymph nodes that we're seeing. So this either had hallmark features of potentially an infective collection or potentially like a heterogeneous mass, which would be even worse, I guess. Sort of decent size, kind of 3 by 2.5. And then we tried to get a radiology scan and have a look, and we saw the same sort of thing. There was some lymph nodes. This is the little submandibular gland coming in. It's normally triangular shaped. It's just a bit cut off, but it's within that sort of region. And then lymph nodes. One of these is probably carotid, possibly that, I can't tell in this image. But then this whole thing was visualized again. So again, we were able to justify going to get an MRI, which we did. We did some bloods along the way, which showed not too much excitement, bit of an inflammatory marker rise, but I know it was a big worry based on what I was seeing on scan. So we got an MRI, and this is what we found. This quite sort of worrying deep space neck infection, which was impacting on the upper aerodigestive tract and deep neck spaces. These are the different phases of MRI, which I won't go into because I can't. But yeah, quite a worry for a child who looked well. Any questions about that case at all? Anything to do with the scan or anything else?
What was
No,
the final
everyone.
diagnosis?
Yeah, so it was I should have put that in, shouldn't I? Actually, yeah. So it was a retropharyngeal abscess. Sorry, I don't know why I didn't put a slide on that. Retropharyngeal abscess, of which he was treated with initially IVs, obviously, and then stepped down on oral about 5 days later and did do fine, didn't need any operation, and actually kind of clinically didn't, present maybe the way you would think someone would. For example, I know adults can be quite poorly with such conditions, and I haven't seen many of them. But yeah, he was, other than a little bit of mild posturing, he wasn't too bad. So yeah, kind of all abscess based. But I think at this level, it's hard to be absolutely certain because it's extremely heterogeneous. It's obviously quite a well-established abscess. It's not particularly hypoechoic if you look at the differentiation between that of the lymph nodes. So yeah, quite an interesting one. Okay. So again, this boy was an interesting case, and he came in with some painful urination, and he'd had this sort of on and off for a period of time. He'd been seen by his GP, and he'd been given some courses of antibiotic for query UTI. I don't know what the dips showed. I don't think a lot, other than possibly at times bits of blood. No micro was sent, which I think is never helpful in pediatrics. It's just the way we tend to do it, just to close that loop off. I know in adult practice it's not as commonly done. But I mean, I'm just going to come out and say this. I don't think boys get UTIs. I can count on one hand the number of boys I've had with a UTI outside of the neonatal period in my whole career, I think. So we'd have to be really convinced, or something else going on structurally, of course, to really go down the route of thinking UTI is top of the list. So I thought it was a bit odd. He just passed blood it was just blood on his dip, sorry, and a clear urine. So I thought I was going to end up in this scenario, which happened just a few days before, where I put a probe on a girl's left upper quadrant who had the same story, short history of dysuria and possibly some frank hematuria. And instead of seeing a kidney, I really just saw not a lot of kidney and just a huge, enormous hydronephrosis. So this is the renal cortex around the outside. We've got these massively dilated calyces where we've gone even before the kind of beyond the sort of bear claw, bear paw deformity where you get the kind of, it looks like a bear's paw here. Instead, it's just all urine, isn't it? So it's a massively obstructed unilateral hydronephrosis. The cause for this girl was unknown, actually. The thought was all potentially congenital, just with tipping over, but she'd had no symptoms at all in her life. And she was 16. So I thought that's what I was going to see, potentially, something like that. But I didn't. I saw something a bit more interesting. Okay, so does anyone want to talk through what we're seeing? This should be hopefully not too confusing for those who do some scanning, maybe adult people if they do some scans as well.
It says bladder.
Good.
Is he? There's obviously some density at the neck of the bladder that shouldn't be there.
Yeah, definitely. So we've got a small bladder, all right? So we've got kind of lower rectus abdominis, so it could be transverse abdominis, depending on how deep we are. We've got muscle there. We've got a small, Americans call that the toast view, of the bladder. It looks like a piece of toast, kind of cuboid. So it's quite small little bladder. And then this is meant to be longitudinal. Well, it is. We've got some bowel gas. And yeah, we've got an inorganic piece of material, haven't we? Got hyperechoic. It clearly isn't anything that should be in the bladder. And it's creating excellent acoustic shadowing throughout. So it looked really like foreign bodies to me. I'm like, wow, that's a foreign body. That's a foreign body there and there. Almost gives that appearance of a gallstone, doesn't it? So I was like, wow, okay. So it was a bit strange. And I thought, boys don't, say it again, boys don't get UTIs. What's going on here? So I'd found this and I wasn't expecting to find anything, to be honest. I thought, we'll check his micro and he's well, and who knows, I don't need to worry too much about this young lad at all. This is a measurement of them. Object's really big. So in total, kind of there, it's like almost 5 centimeters across, which is pretty huge for a bladder, for an object in the bladder. So as I say, I wasn't sure. I just turned to him and sort of said, could there be any reason why anything might be inside your bladder? Have you done anything like experimentation or fiddling around? And he sort of was quiet for a while. And he sort of looked at me and he sort of said, I said, should we have a chat with just me and yourself without your granddad there? He was in with his granddad, who he lived with. And he said, yeah, is that all right? He went out. And he sort of openly told me that he had been experimenting on himself. And he'd said that he had inserted some things through his urethra, and he'd done it on a few occasions, but hadn't had the nerve to kind of tell anyone, and had just been back and forth being treated for UTI. Does anybody know what this is on the screen? 100 points if anyone can tell me what this is and what the link is. Anyone? Anyone good at Greek mythology? So probably still won't be clear. This is something called a pithos. A pithos is a large storage jar, and this is meant to be the origin for the term Pandora's box, which is from Hesiod's 700 BC poem Works and Days. And the story was that Pandora was the first human woman created by Hephaestus. Some Greeks are going to be unhappy with me for that pronunciation. And that ultimately this jar, which is a pithos, this thing here on the right, had been opened, which released a lot of unexpected troubles. And it was felt that this was missed in translation from Erasmus of Rotterdam, who then it became translated into a box, but it was never a box, it was this jar. So Pandora's box, Pandora's jar. So I'd opened a bit of a Pandora's box here with this young lad when everything that came out followed. And this is what I mean by sort of, different cases today, POCUS sort of saving our big and that kind of thing. So we undertook our kind of normal heads history that I would do with him, that I did individually. And he told me lots of worrying things. He basically told me he was suicidal. He said that he lives with his grandparents and that they're extremely strict and old-fashioned, and that he can't be himself, that he would prefer to be known by a female name, and that he had issues with his sexuality, they didn't feel able to raise with his family, as he described them as issues, unfortunately, sadly for him, and that he ran away on a couple of occasions for more than a week down to the south of the country, and that he'd already tried to take his own life once. So all of this came about from finding something in his bladder, which I suspect wouldn't have came up there and then otherwise. And he went to have a cystoscopy and they found all of this volume of blue tack balls in his bladder that he said he'd pushed down using a stylus from his phone. And he kind of alluded to the fact that he might have been doing that as part of kind of experimentation, or kind of taking on embodying a sort of a kind of a female gender, so to speak, was what he said. So he was we involved the Children's Services team and ICTS team, and kind of actually what happened is really got really good input around the time of discharge from actually the psychiatry team, who felt there was enough there to really kind of dig into, and he was going to get kind of excellent input, which I was really happy about. So yeah, so I guess learning point was just that, we did a scan, we found something, and we had to be prepared to kind of act and think about that, not just for the medical side of it. Me explaining my findings and saying that this is a really large foreign body or multiple foreign bodies in his bladder, and he's probably going to need a GA or something, showing the urology team the scan, and then also, most importantly, dealing with all of the other kind of social difficulties that this young man was facing in his home life. So I thought that was an interesting one. Does anyone have any questions about anything about that case? No? Okay, we've ran over a little bit, sorry, because of the technical issues. If people are happy to stick on the call, I'll just run through. I've got kind of two ones left. I can just do one of them, or we'll see if that's all right with everyone. So this was a 10-year-old girl I saw a little while ago who came in with a sore throat and then also some headache. Not a great deal had sort of happened. It hadn't particularly progressed. And the girl had been seen in the paediatric emergency department a few days before with what was felt to be an upper respiratory tract infection, but returned with some swelling around the left eye. She was afebrile when she came in. She looked all right. But the team who initially assessed her felt that there might have been potentially the element of ptosis of one of her lids. And was it puffy, or was it, infection? So they assessed her and they did some bloods. And again, quite significant bloods to speak of, without obviously a kind of cause that would explain it in terms of enough of findings or signs. So a lot of protracted stuff happened over those following 2 hours before I came in for my shift on a weekend. The registrar did brilliantly managing things. She'd undertook a CT of the orbits, which showed some pansinusitis, which again, something we find not uncommonly. And then the ENT team were involved. They needed some more information. They recommended contrast with the CT, which happened, and then an MRI, and an MRI was undertaken. And around about the time I came in, they asked me, would I come and have a little look at her? They told me the kind of story to date, and that the MRI report was going to be awaited. And I was called in because she dropped her GCS completely, and she was difficult to rouse. She wasn't opening her eyes, and she wasn't really speaking. And her right eye looked fine. And when I looked at the left eye, I didn't really see a ptosis. But to my absolute horror, I found a fixed dilated pupil on the left side with nothing else that I thought explained it. Not a chemosis, like a bad orbital cellulitis, just more of a what felt kind of more neurological. So she was really worryingly, she really, really worried me how she looked. So again, I put the probe on and had a little look. And I had a look for this thing called optic nerve sheath diameter, which is looking at the margins here behind the eye, which is contiguous with the subarachnoid space, gives a real-time relationship to intracranial pressure. Loads and loads and loads of studies have been done on this in different settings, all with decent, really good kind of performance criteria, alongside intracranial bolt devices to measure. The best story I sometimes tell is the best study I've ever heard of was someone was at a conference and they shared it with me. They said that they did the real-time application of hard collars in healthy volunteers and measured optic nerve sheath diameter to look for the changes in diameter consistent with, reduced venous return, increase in intracranial pressure, and it showed a positive relationship of that, which I thought was absolutely fascinating, given that we know collars can be a problem. So the normal measurements taken here from the back of the eye, 3 millimeters posterior, and we're typically going across thereafter. And we're hoping that this is going to be certainly well under 0.55. Probably, there's different cutoffs that have been taken over the years, and this has been a majorly well-studied area, but different levels of specificity based on levels, cutoffs of where we should be. But at 0.68, this was extremely, extremely dilated, but without papilledema, which would have shown, as it did in the other case, as a protrusion of the optic disc here at a greater height of more than 1 millimeter. It's very, very easy to do, just binary for papilledema. It's much better, obviously, than us trying to struggle over doing fundoscopy. But that's a late sign. Papilledema, as you know, is a later sign. So I had a girl who completely dropped her GCS, who was only found to have, on a head CT, pansinusitis. So we gave her some hypertonic saline, and I said, look, I'm really worried about this girl to her parents. We need to kind of act and get her transferred out very quick. And something really strange happened next. So this was the report for the MRI, which was the same: pansinusitis, possible meningeal irritation, but would need further consideration. So I was on the phone to the transport team at this point, having given 2 rounds of hypertonic saline, moved to resus. I said, we need you to come, straight away, time critical transfer, for something that, is unclear at the moment. And when I was on the phone to the transfer team, I was getting another phone call, and I had one of the nurses frantically waving at me saying that you need to come off the phone. Someone needs to speak to you. I said, well, who is it? Because I'm on the phone with the transfer team. They said it's the neurosurgeons, because we'd packed the images across, obviously, and I think, anticipating the transfer. And I just said, but I'm giving all the details, I was running through the ABC of the girl. I was like, I can't. She said, no, you need to come. So I says, 1 second, excuse me. I went to the other phone, and I had the neurosurgical registrar on the phone, who I never forget, she said, we need this girl here yesterday. They said she's got a subdural empyema that's causing mass effect. I was like, right, okay, what are you seeing that several other people, including radiologists, haven't seen so far? That would certainly explain the bloods, wouldn't it? And the fact that she's just dropped her GCS. But yeah, she said, you need to get her here now. So we put her in an ambulance, and the anaesthetist went with her, and she went to the tertiary unit. And basically, something that happened that I've never ever seen before in my life. She went straight from time critical transfer to the other hospital and went straight to theatre for evacuation of a subdural empyema without parental consent, which I think is absolutely remarkable. And thankfully, they drained a subdural empyema, and she did very well. So I thought it was a strange case for other reasons as well. So optic nerve sheath diameter is really well studied and reliable. Obviously, there are different cutoffs about what you do in terms of how big, where you measure from, and things like that, and probably needs ongoing work to fully validate. But I've used it quite a lot in concerns about shunt dysfunction, or kids with IIH, or kids who I'm just very happy they don't, that this shouldn't be papilledema. They don't have papilledema. This story is not a worry. We can be followed up as an outpatient. This is not a worry. So it is a really nice, useful tool to use if anyone is into it. There are now different ways about where we should measure exactly in terms of the margins, but again, it's just ongoing work. And I've linked up with one of the guys in Toronto who's very big at this, called Mark Tesaro, who give a lecture, and he did a lot of the early studies about kind of 7 or 8, 9 years ago on this. And yeah, it's ongoing evidence, but lots of evidence, I have to say. Any questions at all about that case? No? Right, this would be the last case. Would people prefer that we wrap up there? Thumbs up for wrap up, or thumbs up for last case?
Last case.
Okay, cool. People are happy to stick around, I'll do it. Sorry about the technical stuff. So this is a case of shape.
Someone wrote more.
Sorry?
Someone wrote more.
I can't hear what you're saying, but it sounds funny, whatever you're saying. What do you say? You want one more?
No, someone wrote on the meeting chat more.
Cool. I'll do it really quick, right? But this definitely fits within this category, this saving of bacon. So I have shared this case before at teaching, and I think on one of the first ever talks we gave. So this was the girl, 16 years old. She came in, and her only complaint was that she'd had rattly sort of breathing sounds, and that she could hear popping candy when she was swallowing, or that when she was doing a deep breath in. SATs were completely normal, and she looked completely normal. And she was at the doors to be streamed to the urgent treatment centre when I'd just done some of my early POCUS stuff at the university, and it was a nice summer's day, and I thought, well, I would like to just have a little look at this girl and just do some scanning, because there was a couple of potential things I was thinking could be going on, but she looked so well. So obviously I'm going to do POCUS lungs, and I'm thinking about interrogating this pleural line to see, kind of funny sounds, breathing in, unilateral chest pain. Let's just double check she doesn't have a pneumothorax. She shouldn't do. She wasn't particularly tall. So everyone's familiar with this scan that we do, high frequency probe and longitudinal, rib shadow, pleural line. You're looking for those ants marching along a log. So on the left lung, everyone happy we can see some nice pleural slide shimmering along? Yeah. What about on the right?
There's no obvious lung sliding.
There's nothing, is there really? No. We talk about this. I always talk about this, ants on a log, like a Disney film. marching along. And we really can't see that, can we, with a deep breath in? We can see the movement of the rib as the muscles expand slightly, but we can't see the pleura. So we put M mode on. This is obviously our classical seashore barcode signs differences. So the movement or artifact caused by M mode, movement over time with a grainy sandy beach caused by the movement artifact. Whereas in a barcode, pneumothorax concerns, when you're going to see everything external to the pleura here and everything internal to the pleura within the lung looks the same, because there's no functional lung movement. That column of air is not moving with a breath, and we're not seeing that movement artifact. So do we think she's more seashore or barcode?
Barcode.
Yeah, it looks exactly like a barcode, doesn't she? So I was like, wow, why are we barcode? This is bizarre. She looks very well. She's got normal sats. And worryingly, she was barcode everywhere. Okay. So I hear you say you can't rule in pneumothorax with lung point. You're completely right. With POCUS alone, it's a rule out test, and you're totally right. Would need to identify lung point, which would be the interface between the normal lung and the abnormal lung. And if we find it, would give us 100% sensitivity based on a lot of the studies of being only caused by pneumothorax, not caused by something else, such as an absent pleura or something else that could be going on, endobronchial intubation or something like that. So instead, I had a look around to try to see if I could see this region of slide and no slide, sandy beach and barcode, and I couldn't see it anywhere in this very, very well girl. And I was looking up in the Excel and down. I thought, what am I doing wrong here? This is unusual. And the reason I couldn't see it is because this well girl with SATs of 90, who had been only having a sensation of popping candy on and off possibly for several weeks, had an entire hemithorax pneumothorax. So that was very odd. So we drained it as per BTS using initially aspiration, which was probably pointless, didn't work, 50 times 50 mils. And so then I put in a chest drain, which was fun, first time in a little while. And the girl ultimately went for a VATS procedure, but then also had recurrence. So it was one chest drain within 10 years for me, and then 2 chest drains within 1 month for me, which was interesting. We don't know why she did that. It wasn't marfanoid. So again, POCUS for pneumothorax has good sensitivity and can be helpful. I always used to struggle a bit seeing that line on an X-ray. It doesn't mean that we're going to replace the chest X-ray. It just means that alongside various pre-test probabilities, it's going to be able to reassure you to discharge a patient home, or in our case, pick up something kind of more worrying, if that makes sense. So overall thoughts to wrap up were just that, look, kids, for those of us who work in the PGD, they're incredible at hiding things. They can look well when they're poorly, and they can look poorly when they're fine. Uncommon things are going to land on our doorstep, be that a genetic diagnosis, something big, social, sort of Pandora's box, or, things that have gone on since birth, like a missed 2 years worth of congenital hip dislocation. POCUS really does no harm. We're all practicing well within our own competencies in our departments, underpinned by our own governance and our department guidelines, backed up by research that we've either contributed to or that is published elsewhere, and that I'm not going around and scanning thyroids and sending them home, or breast lump masses. We're doing all of the things that we've been trained to do, which in my case, I've been kind of doing it quite a while now. And I think, look, it's fair. It's hard to argue against the fact that it could directly or indirectly potentially save life or limb or something else. So I'm done. You'll be glad to know. I hope that was all right. I'm going to get back to see the other screen. Does anyone have any questions? For those of you who've hung on long enough. Any questions? No, stunned into silence. Nigel, are you back or not?
Yeah.
No, he's oh, you are. Did you hear about all the technical issues we had?
Nope.
No, we had some. That's all you
Well, I
needed.
haven't.